Good evening, good evening, good evening, good evening, Facebook friends and family, to all of our Instagram, Periscope, YouTube, and all of our social media families. Welcome. It is Monday night, and what is Monday night? Monday night is Couch Conversations with the Doctors. So, welcome to Couch Conversations with the Doctors. It's your Monday night dose of health is wealth. So, come on in. Remember to share, share, share. Start your watch parties. Hey, Yolanda Williams. I see Yolanda is checking in. So remember to check in, start your watch parties, share this page, and remember, most of all, that health is wealth. So share your page and start your watch parties once again because what is it? It's Couch Conversations with the Doctors. I see Cassandra Galloway, Marvelous Harris. I see Sean Kennedy and Martha have checked in just as well. I see Carrie Steele is here, Marianne Scleropoulos, Audrey Jaycox, Karen Yarbrough, Alderman Pat Dow. So thank you guys so much for checking in with us as we begin to have our couch conversations with the doctors. Oh, and Yolanda, I see that you started your watch party. Thank you so very much. We're going to go around the table as we always do, and we are going to do our introduction of our great panel of doctors who we have here, who are here with us on this evening. I'm going to start with my co-host with an S, who is always here with me. So, of course, you know one of my co-hosts, he's an infectious disease specialist over at Near North Health, but he also thinks that he's an adamant cook. I really don't think Dr. P can cook. We can actually challenge him as soon as COVID is over with. So, Dr. P, why don't you introduce yourself to the people?
Listen, Nikki, as long as you don't start no I can cook ribs thing, because I don't want to get too early for me. I cook all kind of stuff, but hey, I just want to thank everybody. I'm the Director of Medical Support Services at Near North. I'm actually a general internist, but I do HIV medicine as well as general medicine and public health stuff. So I'm excited to be here today.
Wonderful, wonderful, wonderful. To the man who says that I threatened him to be here, but you can do that with his family. That's Dr. James Miller. Dr. Miller, can you introduce yourself to the people right here?
Just good evening, everybody, and welcome to our discussion for this evening. We hope that that we'll be able to give you something that is enlightening and something that's going to help you to have better health. Again, my name is Dr. James Miller. I'm an internist, and actually, I'm retired from practicing general medicine, but I still do a little bit of work in the community and more work in terms of doing things to try to improve the direction of our young folks.
Wonderful, Dr. Miller. To that weight loss doctor extraordinaire, the one who says that he is a chef. And I think he has a burning desire to one day be on Hell's Kitchen. That's our very own Dr. Tony Hampton. Dr. Hampton, introduce yourself to the audience, please.
Hi, everybody. I am a family doctor. I work for Advocate Aurora Healthcare. I'm also a regional medical director, so I'm very passionate about wellness and helping people find alternatives to medicine as a way to heal. And so I'm really excited about being here today as we talk about men's health.
Wonderful. To my coworker, who's a retired physician, but guys, if you're paying attention, something's different about Dr. Graham. That's how the haircut. Come on, Dr. Graham, introduce yourself to everyone.
Thank you, Nikki. That's right. I'm a retired physician. I worked in the Western suburbs for 30 years. Last year, I joined Danny Davis's office as a congressional fellow. I'm still working on legislation. I'll try to answer your questions if I can.
Wonderful, wonderful, wonderful. To the world-renowned urologist of all, the man who has been all over the world educating our men about what men's health. That's our very own Dr. Terry Mason. Dr. Mason.
Thank you, and I'm always appreciative to be on this very distinguished panel with my colleagues. And it is my hope that we impart something that makes you a little smarter so that you can make better decisions for yourself and your family.
So to our special guest, thank you so much, Dr. Mason. Our special guest who is here on the panelist, he's one of our panelists here on this evening. He is an awesome gentleman. That's Dr. Obari Cartman. PhD, who is a community psychologist, and I believe he is the president of the Black Psychologists Association. Am I correct,
That
Larry?
is correct. Yeah, the Chicago
So that
Association of Black Psychologists, current president, program director for Real Men Charities, a nonprofit. All of my work is in Black male mental health, and I'm very, very excited about being here, connected with y'all.
wonderful. And did you forget to tell everybody that you were a fabulous African drummer?
I did forget to tell everybody that I was a fabulous African drummer. Yes, it's one of the things I also do and love.
Okay. So in his spare time, he's a drummer. And to the man who leads the 7th Congressional District, the one who is a vanguard on healthcare, the one who teaches us that health is wealth, it's our very own Congressman of the Illinois 7th Congressional District. That's Congressman Danny K. Davis.
Very quickly, I am delighted to be a part of this group. I used to be a member of the Black Psychologists Association. I stopped paying dues a few years ago, and so I guess they take you off the membership roll. But I did sponsor a piece of legislation, and we managed to get it passed a little time ago. It had to do with providing money for college counseling. I co-sponsored that with Representative Osborne from Nebraska, who was a Republican and used to be the football coach at Nebraska when they were the Big Ten champions. And he was a very good guy. We thought he was going to become the governor of Nebraska, but he didn't because he lost his Republican primary. He was a little too, I guess, moderate, whatever it was, but he didn't make it. But it's good to see everybody. I feel decent about some of the things that the new government leadership in the United States of America is doing. Matter of fact, I think Joe Biden has made some decisions early on that I certainly agree with. I certainly agree with my colleagues who are talking about the possibility of generating $3,000 a month. I ain't expecting this to really be that much when it gets down to, but at least there's conversation about putting money in the hands of poor people. And that of all the things that you can do to try and reduce and possibly eradicate poverty, one of the best things you can do is put money in the hands of poor people and let them use it and make use of it. So I feel pretty good. Not the best, because we don't quite know where we stand in terms of the vaccine and getting people vaccinated in relationship to the COVID-19 pandemic. But I do feel like we're going to have plenty of it moving around pretty soon. And ultimately, we're going to get to the point where we are actually vaccinating more than 1 million people a day. And when we get to that point, I'm going to feel much better than I currently do. And I do think we're going to get there. So tonight, I understand we're talking about men's health. And I always wondered why men used to didn't seemingly get as sick as men do now. When I was a kid, very seldom did we hear of a man being sick. And but now, of course, men seemingly are much sicker than they used to be. So maybe this esteemed group of men can tell us why. It's a pleasure and thank you all.
Wonderful. So we want to say hello to Daniel Allen, it's Sergeant Daniel Allen of the Chicago Police Department, to Deborah Cozy Lane, who is here. And the questions are rolling in. So Dr. Mason, our men's health guru, if you can start us off. I don't know if you want to do a conversation, a presentation, whatever.
I'm going to go straight in. I'm going to go straight into the presentation because the images are always good. And I redacted. I took out the images I would normally show an all male group because I never know who's watching on the computer. So I always want to be aware of that. So some of the things are not there. The other thing I want to say is that all of us who are physicians here do male health. Yeah. I mean, they all do it. I mean, I just happen to do erectile dysfunction and prostate, but the male health issue is still cardiovascular disease. And that's what all the internists sitting on this panel do. And they've done it much longer and much better than I do it. So I'm going to try to share the screen and see what happens here. So what we want to do. Now, that's not me. I don't know what that is. So
I can't believe Dr. Mason threw me under the bus.
That was an entree, an introduction. Is that what that was?
Yes.
I thank you.
Just for you. Just for you.
Oh, praise. Well, I don't see my screen, so Nikki, I don't know.
So, yes.
Did you share your screen with Terry?
I did, and I can see his screen on this side.
No, I just need to share it that way. I don't need, because I see the screen that's there. But if we have to, we can just keep going.
Here we go.
All right. Is it there?
Yes.
Okay. Uh-oh, what happened to it? It just left. There it is. All right, Nikki. So I am going to go ahead here and view. All right, how's that? Can we see it? So I always like to start off with always giving homage to probably the greatest man that knew more about medicine, pharmacy, surgery. This is Imhotep. He lived 2,000 years before Hippocrates did, who was often credited as being the father of human medicine, but actually it was Sir William Osler, who was one of the founders of the Johns Hopkins Medical School, who actually restored this and recognized him in the library of the medical school. This man did over 256 different procedures. He treated tuberculosis. He was a dentist. He did a number of things. So I always like to give homage to a man that's a real father of medicine who lived over 2,000 years before Hippocrates. So this is just why I do what I do. And the main thing is that we really need to make certain that we all have the right to nutrient-dense, widely available food. That is the real thing that I'd like to spend my life making sure that we do. So just to give you an example, because they always say something about Black folks, and it's not there's anything wrong with us. It's nothing's wrong with us, which is why we have more things. That's not the problem. It's the things that we have to be exposed to, and we do. This is taken from a book called Western Diseases by a guy by the name of Dennis Burkitt. The doctors on the panel will recognize that name as Burkitt is the man who they named Burkitt's lymphoma after. But what I wanted to show you in this slide, if you look at this is diseases. This is lung cancer, breast cancer, colon, stomach, pancreas, liver, prostate, so on and so forth. Now, all of a sudden, we end up with a whole lot of all of these different cancers more than everyone else. But if you look at it, if you looked at the Black folks that lived in the country, this is in South Africa, they had more esophageal cancer, but they had less of all the other cancers than everybody else, including the ones, even the Black folks that lived in the city, and certainly a whole lot less than the white people that lived in the city. So we want to say that there's something about where we are that also creates the problems that we have. So I know the question was going to be more about erectile dysfunction, but I'm going to show you that that's really something that the internists do treat a whole lot or as much. There are other many issues, the causes of erectile dysfunction, but I'm going to hopefully share something with you that will make you understand why it's so important that I spend so much time talking about food. It's a very common disease. I mean, a lot of men have it. I call it the canary in the coal mine, and you'll see why in just a minute. These are all the things that we say are risk factors. If you do this, if you smoke, you got high blood pressure, whether you're taking medicine or not, if you're overweight and you eat, but this is the main thing, an unhealthy diet. And this is the thing that I think every physician on this panel would agree. And if you looked at just what's happened in this country, this is obesity up at the top over here, and this is diabetes down here. And if you look at all of these look the same. In other words, from 1994 to 2000 to 2010, you saw more and more people with diabetes and more people with obesity. And that's because these two diseases have some very common things in common that make it so. And if you looked at who had high blood pressure, if this is Illinois up this way, this is the South, that's Florida, this is Texas over here. But if you look in the southeastern part of the country where we got not just black folks eating a whole lot of stuff with oil and saturated fat, but a lot of people. So that's why you see this high blood pressure. And if you look at heart disease, it's concentrated in the same area because it's the same problem. And if you look at stroke, it's concentrated in the same area of the country. And if you look at, this is just death rates, period, all around, all races, everybody, including Hispanics. And you can see that this is still concentrated in these areas where we eat a lot of that same kind of food we're going to talk about. So if we looked at what happened between 1950 and 2000, we went from eating 16.4 pounds of chicken per person, per person, to 52.9 pounds of chicken per person.
Oh.
Now, the human being didn't change, but you can thank all your fast food places that are in our community, those with brand names and those without. This is why this is happening. And when you see this sort of food increase in food consumption, you shouldn't wonder why we're bigger than we used to be. We used to eat what is this? This is about 4.1 pounds of turkey per person. That was back in 1950. And now we're eating 13 pounds of turkey per person. We used to drink in we eat about 7.7 pounds of cheese in 1950, but by 2000, that was almost 30 pounds of cheese. This is all per person. And now the numbers look like it's closer to much higher than what it used to be. I wanted to show you that this is talking about oils and milk, low-fat milk. Low-fat milk is probably one of the biggest gimmicks in the world because full of regular milk is just 3%. It's 3% milk fat. So when they tell you you got 1% and they make it seem like it's so much, it's just 2% different. So we used to drink 2.9 gallons of milk in the 50s, and now we're drinking 14.5 gallons. We're looking at eating much more oil than we used to eat. This is from a book called The Hungry Planet. And this gentleman went around the world taking pictures of a week's worth of food for different people all over the world. So this is an Indian family, and you can see on this table that there's lots of vegetables, there's some grains and some rices and stuff like that, but you don't see any meat on these tables. This is another family that they took a week. These are Chinese people, and you can see here's a few eggs and some meat, some rice and grains, and over here, but lots of vegetables. This is a picture of America.
Ooh.
This is a family, a week's worth of food from America. And you can see if you look here, this is a week's worth of food consumption. You see very little fruits and vegetables. Here's a tomato, I think one. And then this is some grapes over here. But if you look at all this other stuff, it's all processed foods. It's not even real. It's a food stuff. And of course, here's the pizza rich with its cheese, creating opportunities to provide us with far more of these saturated fats than we ever need, in addition to all the salt that's in the cheese, because in making cheese, you need that salt. So if you wanted to know about the erections, and this is important because ladies, if you want them to be able to be more effective in a part of the room where you sleep, you need to get far more efficient in eating better things, cooking things in the kitchen. So it's a problem with the inside lining of the blood vessels. Now I'm going to show you that in just a minute. And I won't show the whole thing. I don't know. Can you hear all this?
Yep.
Okay. So what I want to do is I'm going to move this ahead along a little bit, because this is, I just want to set this up. Dr. Caldwell Esselstyn is a man I went to spend some time with at the Cleveland Clinic. He wrote a book called How to Prevent and Reverse Cardiac Disease. And I went there for him to show me exactly what had happened with real data and the real angiograms. So this is about what he did and what he found as they did the study.
So, Dr. Mason, we can't know. So
You having the problem?
Yeah, just tell us what his audio is, because we can't hear him.
Okay, I'm sorry. Basically, what he's doing is he was trying to keep these people from having bypass surgery. And he had a few people in the study, and his study was to put them on a strict plant-based diet. And what he found was that the people that were on the plant-based diet that were that were absolutely doing it exactly right got better. And they got much better. And some of them didn't need to have the surgery that they were going to have. So that was the point. The food, the focus I want to focus on now is, this is the thing everybody should know, and all my colleagues would certainly agree, that if you have blood vessel disease anywhere in your body, you have it everywhere. There's no such thing as selective blood vessel disease. These are the blood vessels that go through all the body. We hear about the ones here on the heart and the ones that go up here. When these are blocked, you have stroke. When these are blocked, you have heart attacks. When these are blocked, you have pain in your legs and you can't walk very far. But the problem is the same. And if you have that problem anywhere in any of these blood vessels, you have it in all of them, every single one of them. So you shouldn't just think that it's in one place. It's all over. These little things here, these are the little blockages that we get in our heart. And then what we do is we put a catheter through, then we put a stent, a balloon in, we blow up the balloon, and then we put this metal stent. I got one of these myself because I used to eat a steak every day, either porterhouse or T-bone, depending on where they cut it. But that's what it cost me. So I'm talking about this from a personal point of view too. This is what we see in the neck. This is what it looks like in the legs. And what I wanted to show you here, apropos to the issue around the penis, is that we were getting ready to do a study on a drug for prostate cancer. But we knew that the drug ahead of time had shown some erectile dysfunction. So in order to figure out the men who already had erectile dysfunction, we did these questionnaires to determine who had erectile dysfunction before they went in the study. So what we found was some very interesting information. So if we looked at, in this group, there were 571 people who had a heart attack. And what we noticed is that 464 of them had erectile dysfunction before their heart attack. Yeah. If we look, and these are all statistics, that's all these other the numbers mean, that it's very statistically significant. If we looked at those men whose heart was unable to pump blood effectively out of the heart, If we look at those 33, we found that 25 of them had it. If we look at men who had strokes, 181 men who reported having a stroke, 157 of those men had erectile dysfunction. And what was the point here? If we look at of any kind of heart event, in these 1,186 men, 955 of them had erectile dysfunction before they had their event. What are we saying here? That the erectile dysfunction is the earliest probable clinical sign that something is going on. And if a man comes in complaining of erectile dysfunction, they need to be thoroughly evaluated because they could be a stroke, a heart attack, or even worse, hiding. So what we want to do, and I'm not going to spend some time, I'm not going to talk about these drugs. These things don't fix anything. All they do is they help stop a chemical that would normally break down a particular enzyme in the blood vessels of the penis. And sometimes it works and doesn't, and sometimes it doesn't. I will not show the issues around penile implantation. I'll just show you that this is what a penile implant is. These two devices, this is filled with saline. These two pieces go in the shaft of the penis. This goes down in the right side, or the right or the left side of the scrotum, and this goes underneath the belly. This is all just saline, salt water that we use, that when we want to make the cylinders firm, you pump the top part of this. It takes fluid out of the reservoir, down through the pump, and into these cylinders, creating an erection. So what else can we do to prevent this from happening? Well, what we could do, the main thing is changing the way we eat. That is always the most important thing. I'm going to show you just a couple of things before we go to some of the other things. But these are the other things that we ask, what causes erectile dysfunction? And the answer here is really the food, because the food is what causes most of these other problems, and even the diseases of the prostate, which I'll get to in a minute. So these are other things that we talk about. I won't show you urethral suppositories or things of that nature. When I have a smaller group of men where I can show this broadly, I'd be happy to. But I'm going to switch now to talk about food. This is the International Agency for Research on Cancer, and they classified different meats. So they talked about classes. Group 1, these are things that definitely cause cancer. Group 2, these may have some degree of cancer causing. 3 is just probably, and the rest of them, the evidence is not as strong. So I want to go to, this is your bladder. This is the prostate right here. These are when a man has an orgasm, the fluid that comes out, about half of it comes from the prostate and the other half of it comes from the seminal vesicles. And this is the bladder right here. So getting back to this one, I wanted to get back to this thing about classifications, because I forgot to talk about that. This red meat is all meat that comes from any kind of mammal. That includes beef, veal, pork, lamb, mutton, horse, and goat. That's all considered red meat. What is processed meat? Any meat that has been transformed by salting, curing, fermentation, smoking it, or anything else. And so these are things, again, the red meat was 2A, that's maybe, but as you get down to these other areas, I just wanted to circle this and show you. They said that processed meat was classified in group 1. If you remember, group 1 was the group that definitely caused cancer. And they talked about, for colorectal cancer, for every 50 grams consumed, that's 1 hot dog or 4 pieces of bacon, you increase your colorectal cancer risk by 18%. So this is important for you to understand. I also wanted to talk a little bit about eggs and prostate cancer.
Wow.
And so what we want to do is also talk about eggs and prostate cancer and its role in actually creating some of what we call some of the more lethal prostate cancer because of what it does. These are the people, and just so we get into just a real quick thing, this is when men should start getting screened. You have that conversation with your primary care doctor to determine when you get screened. You don't have to go to a urologist for that. This I just show because the penis is 3 pieces. This piece and these 2 pieces over here. And that's all connected in a different way. The prostate cancer and the eggs. Eggs are very rich in choline and cholesterol, and they're both concentrated in prostate cancer cells. You should remember that. They're concentrated in prostate cancer cells. I'm going to show you one other thing about TMAO, and I'm going to come back to this idea of what happens when we're eating these meats and our prostate cancers. TMAO, this is trimethylamine oxide. This is a very important cause of inflammation. And it depends on the bugs that are in your gut. And this carnitine, which is one of the things I'm going to show you, there's a picture here that shows you. So this is cheese, this is eggs, this is shrimp, seafood, beef, all of these things. When it goes in your gut, it gets converted to this thing called TMA. And then some things come out of the liver. It's FMOs. These are called flavin monooxidases. They come out of the liver and they create another thing, another chemical thing. This is where the O comes from. It's trimethylamine N oxide. This is a very potent thing that inflames your blood vessels. And it causes the situation that can lead to heart attacks, strokes, even death, but certainly atherosclerosis. And now what we learned about this TMAO is that this particular situation is a function of of people eating these meats. And that's what it does. So it's not just the cholesterol causing an issue. It's actually a breakdown in some of the constituents of these things. Now in prostate cancer, there is an increased choline in the cells of the cancer of the prostate. And we use that when we do certain tests looking to see if your prostate cancer is spread. Oh, went backwards. If it's spread. And so when we look, and I'm going to show you because I don't want to take up too much more time. This was a study that looked at what they did in this particular study. This is cancer of the prostate. What they did is they took men who had prostate cancer and metastatic prostate cancer, and they took some of the prostate cancer cells from their lymph nodes. And then they exposed them to the serum part of the blood of men who were in a study that Dean Ornish was doing, where these men were basically on a plant-based diet, no meat, no eggs, no dairy, and no fish, no chicken, none of that sort of stuff. And they dripped their blood onto these cancer cells that were in sort of like a petri dish. So the men who were in the study, you can see that the growth rate of the cancer cells was only 9%. But the men who were eating the meat and everything else, you can see that the prostate cancer cells decreased by 70% in that group and only 9% in the group that was eating the meat. So I just want to show you that you can see dripping the prostate cancer cells on, dripping the serum from the prostate cancer cell to the prostate cancer cells, that those prostate cancer cells decreased in their growth by 70%, while the ones who were eating the meat, it only decreased by 9%. So you can see that the blood here was far more effective in killing prostate cancer cells. And it also, what we call it, this is just shows a color map of some of the genes that were also turned down that prohibited prostate cancer from showing. So plants work. They're created by a creator. They come and they use the power of the sun, water, and the earth to grow. And all the animals you eat for meat, for protein, most of them don't eat meat, but certainly they eat plants for their food sources for the most part. Cows and all these things do this. So I want you to also understand the word protein is not synonymous with meat. There's a lot of protein in all of the plants that you can eat, and you will never be protein deficient eating plants. So I'm going to stop right there. This is what I call the real pharmacy. Instead of spelling it with a PHAMARCY, I spell it with an F. And I also say that this kind of pharmacy keeps you out of the other pharmacy buying medicines for constipation. Because if you eat this stuff, you will not be constipated, and drink water. So we need to stop with the gimmicks. And I want to thank you. And if you have any other questions, I apologize wherever I stuttered or anything, but I did want to get through these quickly so I could answer questions. And so this is my email. We're going to be doing a program where we're asking people, we're going to do a series of lectures around food, and then we're going to do a detox using just food, no chemicals, no nothing, just food and water. That's all we need. So I want to thank you. This is another, I don't want to show that. This is a great, if you ever get a chance to, so this is Mike Jr., and he's got a great cartoon that he talks about why. So I'm going to stop right there and go back and unshare my screen. Okay, I'm done. And I tried to get that done in 30 minutes, and I think I did it. Any questions?
Awesome job.
Great job, Terry. As usual, every time you give this talk, I feel like I need to clean my refrigerator out.
Well, then go home and clean it out. No, I mean, this is just information. This is not my opinion. This is all things that have been proven scientifically. So this is just not me talking.
So Terry, for the average listener, I know we there was a lot of scientific terms put out, but for the average listener, if you had, let's say, 3 points you wanted to get across to reduce men's risk for prostate cancer, what should we do outside of going to see your doctor? Because I tell people all the time, coming to me to get your PSA is not going to reduce your risk. That's just going to tell you, if your PSA is high or not. That's your prostate specific antigen. That's the protein that the prostate produces. But what would you say a practical application A, B, and C to reduce their risk for prostate cancer?
Sleep, drink water, and eat fruits. Eat more plant-based foods, and try to eliminate the stress in your life, because stress is also something that we underestimate as a cause of disease, or at least an aggravator of disease. So you try to eliminate your stress. One of the things that we underestimate is the power of peace. I mean, just having peace, and I know that's hard sometimes, but just being in a peaceful environment, and you need to have whatever you want to call it, some sort of thing that you believe in bigger than yourself. I think that's important, whatever you want to call that, religion or anything like that. And you ought to treat people kindly. You ought to really try to treat people kindly, because it's not so much for them. It helps you. It helps you when you do good things for other people for no good reason.
Right.
And so I always try to put that out there. And there's some other things that I'll be talking about another time. My 10 steps for a healthy life. And none of them involve any medications. You got to understand too, Pete, that even when they come to a urologist, what they're doing when they do that exam that none of the men like, where you have to put your finger in the rectum and actually feel the prostate. Basically what happens is they're trying to feel if they're trying to feel if it's something hard like your knuckle. That's what they're feeling for. If they don't find it, it doesn't mean that there's not anything wrong. It's just it's not bad enough or big enough to create this nodule. Same thing is true like finding lumps in the breast, or it's the same sort of thing. It's only until the cancer gets big enough to produce that it creates a problem for us to create something that we can see, and hopefully we can intervene in a way that helps not decrease your life expectancy.
So Terry, we have another question that said, what is BPH, benign prostatic hyperplasia?
Oh, Great question, Pete. The prostate is an organ about the size of a walnut. And over time, due to, and it doesn't happen in every man, it doesn't happen in every man the same rate, but there'll be many men for whom the prostate will begin to just grow. Not for any, it's not cancerous, it just grows. Now, the prostate sits at the mouth of the bladder. So if my hands represent the prostate, when it begins to grow, it makes it more difficult for the water to urine to pass through. And so then you notice that you have a slower stream. You have to get up at night to go to the bathroom. And it's not about the size of the prostate as much as it is the way it grows. So some guys will have very small prostates and have a lot of problems using the bathroom. And some guys have very large prostates and won't have any problem using the bathroom. And neither of those correlate to the men who are going to get cancer. So the cancer is not what is about the prostate. It's about the stuff you put in your mouth that creates these changes in your environment that creates the cancer. It's not the things that you eat specifically. You cannot eat specifically for a particular organ. You either eat food that helps you completely or it hurts you completely.
And when you say help you completely, are we talking about reduction of inflammation?
Yes. Yes.
All right. Okay, so I want to say hey to Melanie, who is here. Melvin Ladd says, thank you so much. Karen is sending hearts, and Yolanda says, it is a blessing to be a blessing. That's her motto. And Audrey J. Cox says, amen to that. I have Maria Bryant there saying, awesome. Thank you, Dr. Mason. People are really chiming in with those hearts. And hi, Mary Ballinger, and thank you for being here. You know, we just got to hit those questions, right?
Yep, go right ahead.
All right, Tony, why don't you give us our first question? Dr. Hanson.
I think,
there we go.
I'm sorry. Let's start with the reason why we get an elevated PSA in the first place. So the question is, why do we even get them?
Well, first of all, the most common reason I used to see for an elevated PSA was an enlarged prostate. And if a man came in with urinary symptoms, getting up at night to urinate, not feeling like they're emptying all the time, it wouldn't be unusual that man would have an enlarged prostate that you could feel. Sometimes you could feel it on rectal and sometimes you can't. But the things that we did do then is make sure that they were emptying their bladders. And that you can do now with a very simple device in the office. And you would see your primary care doctor first, and then your primary care doctor would refer you to a urologist if it was felt that was necessary. So usually if it's not inflammation that causes the PSA to go up, then enlargement, sometimes with accompanying inflammation, can make it go up. Now we tell men as they get older, one of the things you have to be careful about is caffeinated drinks. Caffeinated drinks cause increased tone in some of the muscle tissue, and that's some of that muscle tissue is in the prostate. So sometimes you might notice a little bit more difficulty urinating after you have a caffeinated beverage. So if you notice that, then you should modulate that. The other thing is an infection obviously can cause a problem with the prostate. And it doesn't mean you have cancer. You just could have an infection, but it's unusual for men to get urinary tract infections. So if it is an infection, you need to understand if there's a problem with the bladder emptying, or is there some other underlying problem that you have the infection, the reason you have the infection.
Just a follow-up.
First see your primary care doctor and then get your referral to your urologist.
A lot of times I'll tell my patients the day before they have their PSA, I ask them to maybe avoid sex because what can you say about the importance of doing something like that?
Well, an ejaculation can sometimes create an increase in the PSA. Not always, but it can. Mm-hmm. So avoiding sex where you have an orgasm, yes. I think that I try to tell people to do that too, but oftentimes they don't remember. And I'll leave it at that.
We ain't trying to remember.
Okay. Hey, Sherry, a follow-up question is, what would you say to someone regarding the consensus study that argued against getting PSAs? Like, What are your thoughts about that? And is that still something that primary care doctors should pay attention to?
Yeah, I think what it really means is that, in my mind, that you need to have a conversation with the patient about what the PSA is. It's called really giving informed consent. You really need to let them know what it means, because even if it's elevated, it doesn't necessarily mean you have cancer. And even if it isn't, it doesn't mean you don't have cancer still.
Right.
So I think you just have to be honest with the patient about what it does and does not do. And obviously you're going to follow that up with the PSA, and those numbers. I've been out of practice for a while, but those numbers now are the different triggers. And I would defer to the people who are in practice today, because those guidelines did change a bit. And you should always I would always recommend that if you're going to have a PSA, don't do it after a rectal exam. Make sure you get your PSA before you have a rectal exam.
All right. Well, one of the questions says, is there still real sensation after a penile implant?
Absolutely. Because we don't cut the nerves that supply a sensation to the penis. One of these days, maybe we can have a real grown folks video, and I can actually show all this stuff, because I got it, and I've been doing it a lot. Pete knows, they've been to these things, not only the prosthesis, but injections and everything else that we were using. But I forgot what was the question, Nikki. I got myself wrapped up in.
I think you answered the question for the viewer, because the question was there still real sensation after the penile implant? And you
absolutely, absolutely. There's still penile. There's still sensation. The other thing, in a book I wrote back in the 80s called "Making Love Again," people need to understand how devastating it is when a man can't have an erection. And I know it sounds for some people like, why is that such a big deal? Because when a man can't satisfy his partner, this is a real issue. And it's a psychological issue, but it also, because we put so much emphasis in our society around sex, and obviously it is something that's pleasurable for the partners, the people, we have to really understand what this means when men are having this. And I can tell you, in the book that we wrote, and in the thousands of men that I saw over 20 some odd years of doing this, it was something that sometimes is even hard for them to even talk about. And so sometimes I asked, when we used to talk with primary care docs, we would ask the primary care docs to ask the question directly. Are you having any problems with getting or maintaining your erections? And there are a lot of things we had to do early on, because we didn't know much about what to do about this. But now we have far better resources that we can use to help deal with this, because what happens is it creates difficulties in relationships sometimes. The wife thinks the husband's doing something with somebody else. I mean, all kinds of things happen, knowing he ain't doing nothing with nobody. Most things. So I think that we need to have these conversations, and I applaud my primary care colleagues who have these conversations. And it's hard, because when Pete knows, when I was in practice, it was not uncommon that I'd be running an hour behind, sometimes an hour, 2 hours behind, because when a guy finally opens up, you just can't open that and leave it. You've got to follow through on it. And the other thing is that there are a lot of things that bother men that they don't talk about. And sometimes you got to create, of all the things, and I'll say this and move on to your next question, of all the things I dislike about leaving the practice of medicine when I did, was I didn't realize how much of a safe space was created for men to have a conversation that they knew that was not leave that room, that nobody else would ever hear about any kind of way, including their wives, girlfriends, anybody else that they brought there. So it's really important. And this is one of the other reasons why it's important to have an empathetic doctor, but an empathetic homoracial, same race doctor, that the studies show, that these kinds of conversations are really, really important. And they may not care much about their heart medicine and other things, especially if those medicines create an erectile dysfunction complication.
Well, Dr. Nathan, you've answered this question really, and I'm reading it just because I want to let the listener know that we got his question and that you've answered it. But there's a part B to his question. If you guys could chime in and maybe answer that, that would be great. The gentleman says, why do I not feel like a man with this prostate issue that I'm dealing with? Things are not working. Is this normal to feel this way? And how can I explain it to my wife?
Yeah. Well, first of all, I don't know what the prostate problem is. I don't know if he had it removed or what's going on. We need to know more information, and I don't want them to divulge that on the air.
Right.
But it does take a listening ear. I'm sure Dr. Hampton and Dr. Pete, you guys, Dr. Obari, you guys talk to people. Dr. Miller, I'm sure you sometimes men are so kind of relieved when they walk in and they see a black face. And I'm not saying they're not relieved if they see a white face, but, and especially, and even if it is the same color face, if you're not empathetic and if you're not willing to listen or you dismiss it quickly, I don't care what you look like, that's not going to be a good encounter for that man. And maybe Pete and Tony, you guys can comment on that.
Yeah, I don't know if you guys recently, there was a study out about the reduction in Black infant mortality rates if the OBGYN was a Black physician. And that's not surprising to me. So when I heard that, I just immediately knew that what that means is just improved communication. Right away, I just know that what that means is that patient connected to that provider and was able to give that provider more information. It didn't mean that the Black physician was more talented, more skilled. It just meant they had more data to act quickly on things that could have been wrong. So full circle, Terry, to what you were talking about, and that is, I think patients are so shocked to see a Black physician, and they are usually like, okay, now's my time to give them everything that's ever happened to me. And it's like, we can't do it all in 20 minutes, but we're going to try to do the things. And even when I have my students there, I try to tell them we have to play our position. And by playing our position means I got to correct the things that internists correct. And there might be some things that I can correct, like in Dr. Obari's case, some of the depression and anxiety stuff, I can address some of that. But some of that is nice to have colleagues that look like him that I can do a behind the back pass to or a alley-oop to. But the reality is there are a lot of, and again, Tony can tell you a lot, and Dr. Miller can tell you, a lot of internists, we're doing the trifecta: diabetes, hypertension, hyperlipidemia, and all those things are assisting the blockage of those arteries in the penis, keeping the penis from becoming erect, and then causing more depression and anxiety. So it's all one big vicious cycle.
Yeah.
How do we get that point across to policy makers, to deans of medical schools, to admissions officers? Because, I mean, I read that maternal study that you're talking about, Dr. Pete. I happened to run across it, and I ended up reading it, and I was amazed. But how do we convince, I guess, the medical community? I mean, we're going to have 1,000 slots coming up, legislation that we passed that was actually introduced by Representative Brad Snyder as the primary sponsor of it. And of course, I was a supporter as well as other people too. And we still have the shortage of manpower in terms of the numbers of African American, especially, but Latino, Asian, in some instances, physicians who could possibly make a very positive difference if they were there and available.
You know, Congressman, there's a paper, and I'd be happy to send it to you, but there was a paper that looked at homoracial relationships between the doctor and the patient versus heteroracial relationships between, and they use this as some policy to actually, I think, encourage this real push for trying to get more people, particularly African Americans, in these places, because it makes a difference. And it doesn't say anything bad about anybody else. It's just, you know, there's this, and sometimes it's not always the same. Even though you may be the same color, you're not from the. Dr. Wright used to always say, "Everybody your color ain't your kind, and everybody your kind ain't your color." So you got to always realize that being both the right person with the right disposition is what people are looking for. And they did the study to prove it. So I have the copy of the paper.
If we're going to make, if we care about this country and we care about people, we have to be scientists, right? So if the data says that there's a correlation between compliance and somebody seeing somebody that looks like them, and they're more comfortable, then, and we only have, last time I checked, it was only 4% of the doctors were people of color. I mean, Black folk. So but we know we're not only 4% of the population. So if that's true, then the larger society says we have a Houston, we have a problem. And at the end of the day, it's not about me not trusting a white person or an Asian person who's a doctor. It's about a certain comfort level, not just because a black-white thing. It's about a man being a man. A man's gonna not share these emotional issues like a woman will. So you have to get that's already a barrier, just being a man. I mean, men are just not, in our society, we're not designed to be that way. You're weak and you're not supposed to do that. So, and then you combine that with the systemic racism we have, right? So we think about the history. And so now I don't even trust doctors anyway. I may trust a brother that I can relate to, but I don't trust it. So we got to deal with that issue. And then the idea going to the doctor makes me stress, and all they do is give me pills anyway. You know, they tell me to do lifestyle, but they don't show me how to do lifestyle. So they're frustrated with the entire system. So if the people in power, in fact, I would say, if I were to say, write a proposal, Congressman, I would say, well, let's find a way to support those people, like a Morehouse or, a Meharry, those types of institutions of color where they have plenty of people of color, and we support them so that they can then help spread the message that, maybe a COVID vaccine. In fact, when I do a podcast for Friday, I interviewed the president of our hospital, and it's called Systemic Racism and Why Two Black Men Decided to Get the Vaccine. And the reason why I chose this 40-some-year-old president of Advocate Trinity and Advocate South Suburban Hospital, because I felt like he would be relatable and he would be able to spread that message in a way that maybe somebody else couldn't. So that's what I would want to do. Let's support the institutions of color and make sure that they have a charge. Your charge is to find a way, because you can talk to the people, because you understand these people, you're from their community. What is it going to take to get more people engaged, not only for COVID, but for prostate cancer screening, for example? And I think that if we talk to the people in the community and they feel that we care about them, we're not just putting them in a study so we can get data. We put them in a study, and then we come back to them and say, this is what we're finding. This is what we need to do. I need you to stay engaged. Those types of things where we actually show we care. Those are the things that will probably drive change.
Can I just add one thing here? Much of this starts with trust and feeling comfortable with the individual that you are engaging with. And the fact of the matter is that when we look at it, the numbers don't jive in the sense of being able to have enough Black physicians to take care of the Black people. So we got to begin to look at something that there's something that's happened on the way up the chain. our young boys are not, young men and young women are not really either not interested or either don't have a fear. I mean, I found that a lot of young men, especially young Black men, have a fear that I can't do this. It's too much. It take too long. I gotta study too much. And so whatever it is that we are not doing in terms of engaging them, that they will be encouraged. Now we, obviously became encouraged, and we decided that we were going to invest our time and our efforts into trying to fulfill a position that we thought there was a need there. We got to begin as men and women of color to look down at our young people and to say, and to encourage them to do what it is that's necessary to help to motivate them to become involved at an early age of thinking about being a physician. Because if you don't think about it, 9 times out of 10, you'll never be, you won't travel that path. So we need to begin to figure out how we can change things at the early level of their education and how we can involve them in ways that they can begin to feel comfortable, feel enough confident that they can do this and that they can help people that need help, as opposed to having that fear. Because I mean, during my years, that was one of my major things, to make certain that I had at least a few young Black men around me who were, not necessarily even in college, just getting them to the fact of seeing what doctors do and not doing it in a way that they no longer have this fear, but have a confidence that, yeah, I can do this. And then the more I do it, I like that. And I think that we're going to have to address that issue, because that's where a lot of that problem come from. Because even if we say that if we identified all the Black men and women who are physicians, and say, well, these are the people that we'd like you to go see, it just, they would become frustrated because we wouldn't have enough time to be able to take care of all these folks. So the issue here is creating more and steering more young Black men to that area. And even when you start talking about men and their prostate gland and their sexual problems, a lot of them don't want to speak to a woman about that either. They want to speak with a man. They feel comfortable telling them about the things that are bothering them without feeling any kind of shame or any kind of feeling that they're going to be judged in a negative way. So there's some issues here that we've seen these as issues of supply and demand in our community, and we need to figure out how we can increase that supply.
Well, I can tell you, Dr. Miller, when I was at the University of Illinois, you went there too. Our class, the class that entered in 1974, we had 37 African-American students in that class. And thanks to Congressman Davis and all the folks that raised hell on the West Side that made sure that the university was looking at that. But it's not just getting them in, we got to get them out.
Yeah.
And then they got to get in a residency.
Yes.
And I mean, so there's a lot of things that are happening. And one of the things that was, I think, central to our success at the University of Illinois is, Dr. Miller, you probably remember the room, the MOP room, the Medical Opportunities Program room. And that was where you, Horace Smith, upperclassmen that were about to graduate, all the way down to people that were in their sophomore year, that sort of intergenerational support. Because I tell you, even as a student, even when you get in, you might be euphoric that you got in. And I'm not saying this is necessarily unique to just Black students, but I tell you, man, there's a lot that's riding on you.
That's right.
You got a lot, you carrying the weight of not just you got your whole family, because they've all told everybody, and now you just got to make this happen. And you realize that you may not have been as prepared as you really needed to be. And you certainly weren't prepared for the game.
Yes.
Okay? And all of y'all know what I mean when I say the game. And so those are the other parts. And that's why it's so important that we continue doing the things like, Project Alpha was doing, that some of the other groups were doing, that we try to do at the churches and different things like that. Because, Judge Pincham, I know Dr. Davis remembers Judge Pincham. But Judge Pincham used to say, you can't be what you can't see.
Yes.
May Shake Pincham. It's interesting that you mentioned Dr. Smith because his daughter is involved with a program now of with young people who want to become physicians, and some of them are no more than 10 or 12 years old. I ran into them over on the Ogden Avenue, over at the North Lawndale Clinic over there. So people are doing it. They're trying.
And I'm gonna send you something, Congressman. I'm gonna send it to Nikki for Smash Academy. It's one of the many programs that we're working with. It's a science, math, sort of enrichment programs. And there are a few of those that Dr. Whitaker, and you know, when they were at a lot of the things comes out of what they learned from Project Brotherhood, both just not in the taking care of people, but the kind of interaction that you need to be able to have to interact with even your colleagues. So I thank you for this opportunity. I apologize for any of my little missteps along the way. I'm sorry, but we were just trying to get it done.
Yes.
Dr. Obara, you look like you might be a little younger than some of these other esteemed gentlemen. But
I am a little bit. I'm 40 now, and so this is all critical information for me. I'm taking lots of notes over here. About to clean my refrigerator out too from Dr. Mason's presentation. But I do a lot of work with young Black men. That's my world. I'm talking to these teenagers. And to Dr. Miller's point, there is a lot of concern about the motivation, the fear of the study and the amount of work. But what I'm realizing more is that even when I can get them hooked into wanting to do something different than be out in the streets and just be a basketball player, what if I can get them to do it? There's a lack of a skill set. They've been unprepared in serious ways. Some of them really can't read for real. They certainly can't write. So there's we have to go lower than we used to give skills and motivation and mentorship. We got to talk elementary school for this. But the secret that I get to hear in spending my life creating safe space for men to have these conversations is that all men have a story. There's always something underneath the presentation, the posturing, the suits and the ties, and everything's fine. Every man I've ever met is going through something in ways that causes stress, and it's a secret sort of struggle that they're dealing with. And I want to bring back to Dr. Mason's presentation around the emotional connection to nutrition, because it's stressful even hearing all the stats. Like I wanted to cut my computer off half with your presentation because I didn't want to have to deal with the burden of having to change my lifestyle. Right? It's work. It's so like it's the difficulty of life already leads me towards these comfort foods, this emotional eating. If I'm already stressed, if already hard being a Black man, I'm a father of 2 kids, already hard. Now I gotta eat good, right? Now I gotta go cut vegetables up. Like it's so much more convenient to ingest those things that are slowly killing us. Yeah. And that relationship between the stress and the emotions and the well-being is bifold. Like you feel better when you eat better, but you also can eat better when you feel better. And so there's a dilemma we stuck in. It's sort of a cyclical place where Black men are stuck, where we don't have the safe space to deal with the stress. We bombarded every which way. And now there's this new thing where it's easier to not even know what my numbers are. I'd rather not even know what my blood pressure is. I don't even want to get the COVID test because now if I deal with it, now if I know it, but the STIs, now I got to address this as an issue. So the oblivion creates some space for some hope, for some reprieve. And that if we're not dealing with the interconnection between all of these things, then Black men are going to stay away from us. Even if we put psychology has the same position. We got 4% PhD psychologists, probably 1% of us that are men. So even if we increase more of us, we get more information. The information is only part of it. There's the emotional turmoil that we also got to deal with. And men, as y'all been saying, it's hard for men to do that. We don't want to address it. And part of it because we don't have the skill sets or the resources to do. And once I reveal it, once I express all my traumas, the world don't even really care all the time. The world might give it back to us. We're like, well, you're a man, deal with it, take care of it. That's what you're supposed to do, is carry the burden. So we end up, again, spinning ourselves in circles over and over again because of it.
And that inability to resolve that aggravates, and I'm sure my internal medicine colleagues can talk about that, aggravates their blood pressure. It may encourage all kinds of other negative behaviors, even among physicians,
Mm-hmm.
even among professionals. It's no different.
Yeah.
It's no different because a lot of these guys, they don't have any place to take anything.
Yeah.
And I mean, I've seen it in all areas: a rich, poor, big preachers, little churches, mega churches. It doesn't matter. It doesn't matter because and if you listen to them, many of them have the same chorus and verse in their song. And it's tough. It's just really, really tough. And we're still trying to deal in this situation. It's a whole nother topic. And one of the things I do, I was just talking with the young guys the other day. I said, I grew up in Chicago that had 23 black automobile dealerships,
right,
7 black banks, a plethora of stores up and down 87th Street, Cottage Grove, all the places I talked to some of the older people in their 80s who tell me about, and Danny, I'm not going to put you on this spot, but they tell me about the glory days of 39th Street, 43rd Street.
Mm-hmm.
They talked about when, I talked to Pops, he was like, before he died, he was like 85. He said, man, people used to have suits and ties on with shine shoes just walking up and down the street.
Mm-hmm.
There was a different kind of pride that folks had in those days. And when they went out, they had on full ball gowns. And when they went to these different clubs, the Lisa or whatever it was, I don't remember the names of the places, but all of the major artists who came to perform always came down to the places on the low end of 39th, 43rd. Because that the congressman, you could take it from there. I don't know. I'm out of my league now.
Out of my league.
Well, Joe Harrington and I were with Tim Black yesterday. And of course, Tim's only 102. And Tim and I are going to tape something next Sunday that we're going to be doing. And so Joe Harrington can tell you all about
it. I think that's a super important point, though, because what you're talking about is a sense of worth and value. And if you got a bunch of black men that are running around that don't have that internal sense that my health and wealth are worth investing in, then we settle for mediocrity. We accept survival state. And these days, my generation of men, we wrapped up in this cancel culture. There's a narrative about throwing black men away right now. So the story about the criminal black man and the worthless black man, and now the sexist Me Too black man, like there's so much in our culture that's saying that we're not even valuable enough. So you talking about going to the doctor, eating good, taking care of your mental health. Like if you don't believe that you're worthy enough, then none of this stuff matters. Yeah. We all just giving good information and good charts into empty spaces because the men don't feel like we valuable enough.
So Abari, it's awesome that you made that point because there's a question here that says, do real men get or depression?
Absolutely.
Oh yeah, for sure. I mean, that's the box. That's the rigid trick box of being a man, is that we aren't allowed permission to experience the full range of human emotions. That we get this very narrow, maybe anger. And even then, you can't even express anger sometimes. The police pull you over, you express anger, you lose your life. But like the truth is that we get all of it. And we are human beings. That we get sad, we get grief, we get shame. We just don't get the same space to share that. We get you weak, or you know what I'm saying, you go into, so even when a man cries, we call that getting in touch with our feminine side. But it's a trick bag. It's none of it's real. The truth is that we are humans and we all get dinged, we all get bumped and bruised, and that we have to find some way to grieve and to be afraid. All of the things that are happening are human things. If you're not a little bit sad this year, if you're not angry right now, if you're not a little bit afraid this year, then something is wrong with you. That's what it means to be a real man, to be honest, to be full, to be holistic. And we have to teach young men there's a space for that. Even if I'm like on the streets, they can't hide. They gotta hide some of it for survival, to navigate. We need to create some space where at home, in your journal, in these men's groups, and some other space in the barbershop, we got to create spaces where everybody gets to be full 100% human. And men don't have that. We just don't. There's not a lot of spaces for that.
Dr. Barr, to your point, when we were at Project Brotherhood, we would routinely have Black medical students that would come to the clinic. And after a while, we had about 5 or 6 Black male medical students. And so for a little bit, we were like, why are you guys coming here? And then it hit me, they are never around a group of Black male physicians. And so they told each other, hey, let's go study on 63rd and Woodlawn, because Project Brotherhood is there and there's 4 Black male physicians there. And so it's that protected space that I think that allows people, again, to have that full range of emotions. And so sometimes it would just be us coming back there saying, hey, y'all okay? What are y'all studying? Oh, don't worry. That kicked my butt too. You're going to get over it. And they're looking at our face saying, well, wait a minute. So you had problems with biochemistry too? Yeah. But look at me. Here's where I am right now. So I agree with that. We got to create more space so that our men can experience that full range of emotions.
But Pete, it's not just when I said about leaving practice and that space being gone.
Yeah,
I'm talking about guys that were very successful business people. I mean, professional men, but they hit a low too.
Yeah.
They hit lows too.
Yeah.
And they and because they may be well recognized, they're even careful about where they go or who sees them go in what space or who saw them at my office. Or what's wrong? It's something that just keeps going, man. It just keeps going. And then the food, one time we got to do something about food and how we're programmed, how our taste buds are programmed to oily, crunchy, salty. There's a reason why we got so much blood pressure. And and even though we go to our internist, whatever you give people doesn't make their blood pressure go away. It improves their number, but the underlying cause is what we've got to make people understand that there's still some things you got to do. So I'm grateful. I'm really grateful for what you guys do every single day. And it's tough. Having done it for 30 some odd years before, I get it.
Yeah. Well, the other thing that I'm hearing here is that we also need to create some kind of a identity pathway. As we're talking about men that look like us who can't find how to connect and find a space where they can ventilate, where they can let go of the steam that's building up, so they become a pressure cooker, and all these emotions and things they have to hold inside because they're afraid that they can't express it to somebody without some repercussion. So I think that we have to create that kind of environment that men can come and they can go and be themselves, regardless of what that mean at that time, without a fear that they're going to hear on the next corner. And a lot of doing the stuff that I've been doing of late, and talking to teenage young men of that age, the same problem exists because when we talk to them about certain things that they need to look at and need to change and that kind of thing, then they want to do it, but then they have problems when they are in the street. I need to look like and act like the guys on the street in order to be respected by the guys on the street, or I will suffer some repercussion, or I will be taken advantage of. So there's a lot of things here that we have to we look at the problem. We gotta peel off these coverings and figure out how we're going to create environments and situations that those things can be dealt with in a different kind of way than we are now, because where we see things are going now is just not really where we want them to be. And so we're going to have to a dialogue is the first thing, but next we got to create relationships. That's where we can begin to make some changes, because if we don't have a relationship with people, it doesn't make any difference what we say to them. They're not going to internalize it and to act on it. It's when they have relationship with someone and a trust in someone that they feel is being honest with them. That's when they can begin to look to make a change, or change wherever it is that they are doing. So, that's something that we need to figure out how we can do that better.
So, I am about to say something that nobody wants to hear, and that is, we've exceeded our time. I know, right? I am so sad. Our viewers, because I see everybody saying me too, part two, me too, part two. There are so many layers. I mean, they're pouring in. So, Dr. Mason, you know what this means. And Mel is saying no, but we do have to go. But we'll be back next Monday. Next Monday, we'll be back. So quickly, we're going to, there is one question that I have to ask the doctors, just one. One really quick question, and that's because this young lady has asked this question a couple times, and I want to just put this question out there, and if we can answer for her quickly, it would be great. She says, I have questions regarding men's health. I do wish to remain anonymous, please. My father died 5 years ago from esophageal stomach cancer. He was always at the doctor trying to detect what was wrong. Doctors didn't give us any answers until he dropped 40 pounds in 2 weeks and a visit to an ER. He was already in stage 3. What more should we have asked or done? At last, is what if a man knows that it's important to go to the doctor, but will not go or make time to do it until you push or shove? How can you encourage without nagging?
I'll just briefly say that when men, I don't know if this situation was a family that was at the doctor's office. The number of times I've had men see me and wait until the very last moment to share their diagnosis with their family is actually quite high. So my assumption is that they really weren't at the doctor's office every visit. And so that's my assumption. Obviously, if they're at the doctor's office, you just don't settle for a 20, 30, 40-pound weight loss without an explanation. So you're asking that primary care doctor, if that's who you're seeing, to, you want a plan that will directly answer that question. And you also need to be comfortable saying, are there other people who are your colleagues who are specialists who may also help us find answers? Sometimes if people are losing weight, we will refer to the gastroenterologist. So I think a lot of it is taking advantage of the team approach to healthcare. It could be something as, I'm taking a medicine that I shouldn't be taking that can cause weight loss. It could be, did the doctor ask the simple question, oh, I just got some dentures and I'm just not eating right, because I can't eat. It could be something it could be stress. So I think it's important that the family talk to that patient, and then the family collaborate with the doctor team and the other team members to help find answers. This is a detective field. We are just detectives, and our job is to play detective. Now, we can't play detective if we don't have all the information, right? So it's really about harvesting information in a respectful manner without scaring people, and then helping them to achieve their goals that way. So that's kind of how I approach that. I guess anybody else can add their thinking.
Yeah, I will say that, yes, when we're concerned about someone that we love, and we don't want to invade an area that they don't want us to invade, but sometimes we have to go beyond boundaries a little bit when we see that things are not really improving or getting, or we don't have answers. And so sometimes an individual may need a little pushing because of what they're dealing with. Sometimes it's fear. remember many times that patients have come and I've asked them questions, and when I actually got the answer, I found out that they really didn't want to answer because of their fear and concern about what had happened to somebody else. They hear a story that somebody went to the doctor with this, and the next thing they know, they was in surgery or in the OR getting this done and that done. So people have all these concerns and fears are a devastating emotion to have, because it can totally cripple and paralyze you, and it becomes a roadblock for you actually finding answers and finding cures that was there, but you just weren't able to get beyond that.
All right. Well, it is that time, and we usually ask the question right at the end, until next Monday. So first of all, Dr. Mason, your part 2 is next Monday.
Part 2. What am I talk about next Monday?
I don't know.
What am I going to talk
about offline, Karen?
We'll talk about that offline.
But
you don't know how many slides I had to pull out to get this one right.
What would you like to leave with our viewing audience until next Monday? Doug?
Yeah. So I've been thinking about this, and I know that we've been hearing in the news that there are new mutations to the virus and what happens then. All I can say is, as you read the literature, it's expected, and they're actually starting to modify the vaccinations too. So just because the virus is changing doesn't mean we have to change our ideas about the vaccine. We still need to go ahead and be prepared for the next steps. That's what they're supposed to do. They're supposed to mutate. We got to do what we're supposed to do. We're supposed to get the vaccination.
All right, Dr. Miller, until next Monday.
Until next Monday, since we've been on this, and I didn't get a chance to bring this up, but Dr. Mason pointed out some of the big issues. One of the things that I was doing a presentation last year on Black men health, and the thing that really seemed to really knock everybody off their feet was the fact that in general, Black men live 10 years longer than all other people, other men, women of other races. And so, we got to take this thing serious about our health, serious in terms of doing the things that are going to prevent us from getting sick, as well as taking things serious when something is wrong with us, to make certain that we get it checked out and not just think that everything is going to go away without any intervention. So take your health serious. That's what I'll tell you until next month.
All right. Dr. Obari Cartman, until next Monday.
Real quick, I want to respond to the question about how to get men into offices, whether it's therapists or physicians. We are not isolated beings. We interdependent community folk. And so if it takes nagging, it takes nagging. But for me, I know that I did not take my health as seriously as I do now until I had children. So I don't want to live longer for myself as much as I want to live longer for my boys. I want to see them grow. I want to be able to play basketball with them when they're 5 and 8 now. My motivation to eat better is connected to my relationships. And so it's okay that you have a wife or a mother or a sister that's encouraging you to do it. But more than the nagging, it's also important to create an environment. So, if you're a wife, then, what you cook, what you buy greatly influences what a man has access to and the kind of opportunities that you do. If you want to walk, you take them with you. Y'all start activities, make it a communal thing, make it a group project, and don't just give instructions, because sometimes that is harder for an individual to do, particularly in the context of the stress and the lack of worth and all the kind of stuff we're talking about. Sometimes we just need our hand held, and it's not okay. I mean, it's not. There's nothing wrong with that. It's okay that we do this as community. Thank y'all for this, though. This was really dope.
Okay, Dr. Terry Mason, until next Monday.
Well, I just want to make sure that we do everything we can to make sure people understand what we're talking about. And if there's something that we say that you don't understand, don't be afraid to send a question or ask for some clarification about it, and realize that you are your greatest asset, not anybody else. You are your greatest asset, and you got to treat yourself that way, because part of us is a whole notion around self-love that we've gotten away from. And I'm not talking about self-adoration. I'm talking about real self-love, making sure that you do love who you see when you look in the mirror.
Dr. Tony Hampton, until next Monday.
Definitely want to piggyback on what Dr. Graham said about this COVID. And, you know, when it comes to mutations, only 1% of the virus is really mutated. So that the reason why the vaccine is still working is because 99% of the vaccine, you know, I used the example when I did the podcast with Rashard Johnson, who's that president I mentioned earlier at our hospital. You know, it's just like your kids hiding behind you know, a tree or something when they're doing, you know, they're hide and seek. Well, you still see their feet and their arms, right? So the virus can't hide from this vaccine, at least at this point. So I'm gonna make sure to share that episode because we talked about the systemic racism first, and then we talked about he shared some personal stories about, you know, you're the president of a hospital, yet you still get treated like others without being too dramatic. So we need to understand the fears that we have, whether we're talking about erectile dysfunction, prostate cancer, or even COVID vaccines. And the more we understand the fears, the better we'll be equipped to help people and to guide them, you know, answer, as Dr. Obari says, what's your why, you know? And partly one of the reasons why I'm on this forum right now is because my why is to help as many people as possible in as many ways as possible. So once you know what your why is and your purpose on the planet, it's easy to spend a little extra time helping people and doing the right thing. So if we can ask, if I'm a clinician, if you're a clinician listening, just find out what it's not your why. And what and you may think this is funny, Dr. Mason, but I said, we're going to talk about your ED, but we're going to talk about this other stuff first. And then we'll get to I jangle that in front of them. It's my hook. Because if you got a man and they're, you know, at an age where this is an issue, I guarantee you, if you address that issue and help them with it, they'll listen to the rest of the story. So that's kind of my hook. And I think we just have to be creative as we try to engage our brothers and sisters.
Dr. Pete, until next Monday.
Yeah, so until next Monday, just listening to my colleagues, I agree with everything that you said. And I would just add to think about the origins of disease, and rather that means the environment that you put yourself in, mentally, spiritually, physically, the foods that you consume, that's the environment also. And to be very judicious and very selective about how you decide to put yourself in a better environment, because from your environment will come the origins of your disease. So I would just encourage the people out there, especially men, and for ladies who care about men, you know, we endure a lot of very assertive women in our lives. Don't stop being assertive when it comes to your man's health. If you need to call to make that appointment, you call to make that appointment. If you say, hey, when you in the room with the doctor, put me on the phone. I want to talk to him. We encourage that. Those people that care about what we're doing, we encourage that. And I will tell my patients, if I feel like I'm not connecting with you, I will say, get Miss Jones on the phone. And I will make you call Miss Jones, because I know she controls the meals there. She's going to determine how much grease and things like that you're going to consume. So, and also just to Terry's original point, you know, we got to find a way to laugh, find a way to lighten the mood, to lower the stress. I mean, that is an origin of disease too. The fact that we're always under the gun. And I know my fellow panel can understand this, just being in school all our lives, we're always under the gun. Maybe sometimes physically, but also just mentally and spiritually. We got to find a way to relax and laugh.
Yeah, amen to that, brother.
All right, Bishop, Congressman.
Well, Vera Davis, if you're out there, you can keep nagging, pressing, pushing. Why did you do that? Wear your coat. Why are you going out without your shoes? But at any rate, I guess if B.B. King was here, he'd say, now you know why I sing the blues. So, but it's really been a great discussion. And all things aren't bad, because I see where the state of Illinois just announced this morning that they were making $31.5 million available to community groups and organizations that we know who they are. Safer Foundation, the Urban League, the NAACP, Habilitative Systems, Bobby Wright, all those organizations that we are aware of that works continuously and consistently with communities to try and bring services and relief to them. The discussion tonight reinforced, I think, for all of us, how fortunate we are, notwithstanding all of the challenges, all of the difficulties. I'm sitting here looking at 2, 4, 6, 8 healthy people, professionals, secure in terms of who they are and what they do, and the knowledge and skill that they have, and how they make use of themselves. And so whenever I'm thinking of challenges, I think of the little saying that, I met a guy walking down the road and he was complaining because he didn't have any shoes on. But then I went a little further and I met a fellow who didn't have any legs. And how difficult and how different. I've got colleagues who come to work in wheelchairs, who have disabilities, but they are elected by the 700,000 people in the communities where they live and work, who have faith and confidence in them. And when I see all of you, I have faith and confidence in you and what you are saying and what you are doing. And I believe that as a result of that, the world becomes not only a different, but a better place in which to live. So I'm going to say thank you. Head home and grab my spinach and cucumbers. Throw a little stuff up there and go to bed.
All right, so remember to join us right here next Monday, same bat time, same bat channel. And as always, remember to please remember to social distance. Stretch your arms out, and if you're touching somebody or they're touching you, know that you're just a little too close. Ask them to scoot over just a little bit. Also, make sure that you wear your face covering. That's over your nose and mouth, not just over the mouth or over your nose, but wear it across both, as you see it demonstrated here, across your nose and mouth for safety. And also remember to wash your hands. Wash your hands, sing a little song, just about 20 seconds will do. Make sure you get all in here and don't forget here and those everything because the life you save may be your own. Until next Monday, we'll see you then. Have an awesome night.
All right.
Good night.
Thank you all.
Take care, all.